A very good evening to all. My name is Dr. Kamal Kumar. I am medical lead from Ajanta Pharma Limited. And on behalf of Ajanta Pharma Limited, I welcome all of the esteemed experts and delegates for today's international speaker program. So first of all, from on behalf of Ajanta Pharma, we would like to salute all of the doctors who are the true warriors in the current pandemic battle. From bottom of our heart, a big thank you to all of the healthcare professionals and the doctors who are frontline warriors in this fight against current pandemic battle. So with this, I would brief about today's meeting. Today's international speaker program, we are fortunate to have a very esteemed and world-renowned scientist, Professor Guido Grassi, as our international faculty for today's meeting on sympathetic overdrive in hypertension and heart failure as target of treatment, role of beta blockers. Welcome, sir. And Professor Guido Grassi is director of Clinica Medica Institute at Milano. He is president of Italian Society of Hypertension and awardee of World Top 10 Hypertension Expert. Our moderator from India is again a very well-renowned clinical cardiologist, Dr. C.K. Ponde, who will set the context on today's meeting with heart rate, a missing link in hypertension and heart failure. Welcome, Dr. Ponde. And we have our panelist, Dr. K. Raghu, who is consultant cardiologist at Care Hospital, Hyderabad. So very warm welcome to all of the experts for today's meeting. A brief introduction of our esteemed experts. Dr. C.K. Ponde is consultant cardiologist and head of Department of Cardiology in PD Hinduja National Hospital, Mumbai. He is gold medalist throughout his UG and PG career, and Dr. Ponde holds a fellowship in interventional cardiology and electrophysiology from Brisbane, Australia from 1993 to 1997. And Dr. Ponde is a recipient of several awards like Paul Harris Fellowship in 1995, Olympian Health Award in 1997, Rashtriya Manseva Puraskar in 1999, and National Prime Time Award in 2016. Dr. Ponde has up to 100 publications in various national and international journals and has delivered more than 500 lectures in various national and international conferences. He has received Inspiring Cardiologist of India Award by Economic Times in 2020, and Dr. Ponde is currently Vice President of Indian Academy of Echocardiography. Dr. K. Raghu is director at NI Labs Care Hospital, Banjara Hills, Hyderabad. He is president of Indian Academy of Echocardiography in 2021, and he was president-elect and scientific chair of IAE Echo India 2020. Dr. Raghu is member of CSI, IAE, and ICC. He is honorary editor of Journal of Indian Academy of Echocardiography in 2010 and 2011. He was member executive council of Indian Academy of Echocardiography in 2007 to 2009. Dr. Raghu was faculty in all of the annual meetings of the Indian Academy of Echocardiography since 2005, and he has been faculty in CSI annual conferences on numerous occasions, and Dr. Raghu has been faculty in European Echo Meet held at Lyon, France in 2008. Before starting the meeting, I would take few minutes of yours to take you through corporate presentation for Ajanta Pharma. In pursuit to our commitment to CSR activities during COVID pandemics, we have provided ventilators, thermal thermometers, sanitizers, and protective gears, etc. to government of Maharashtra and BMC and other agencies. We have distributed food grains to migrant laborers and daily wage earners across different locations and provided medicines free of cost to various authorities and organizations. We have co-partnered to set up 30,000 square feet tented COVID hospital for 300 beds at Racecourse, Mumbai, and 30 ICU beds at 4,000 square feet dome in Worli, Mumbai. We also provided 2.5 lakh meals and ration bags to people affected by lockdown and cyclone Nisarg in Raigad district. Our mission is to serve global healthcare needs with empathy, innovation, and technology. Team Ajanta comprises of employees, 7,500 plus employees across 28 countries. And we have very strong presence in select segments like cardiology, diabetology. Along with cardiology, we have our presence in ophthalmology, dermatology, and pain management. In India, we are among top companies in cardiology and diabetology, and we thank all of the healthcare care providers to pass the benefit of MetXL to the deserving patients. So we have 7 state-of-art manufacturing plants across India and Mauritius also. And along with that, with the strong research and development thrust, we have 750 plus scientists across across India with state-of-art facilities with complete value chain across formulation, development, analytical development, regulatory affair, and synthetic development. So with this, I would request our today's moderator, Dr. C.K. Ponde, to kindly introduce our international faculty, Professor Guido Grassi, and thereafter set the context for today's meeting. Dr. C.K. Ponde, sir, over to you, please.
Thank you, Dr. Kamal Kumar, for that kind introduction for myself and Dr. Raghu. This is the indeed great honor and privilege to be on the same dais like Dr. Grassi and Dr. Raghu. Dr. Raghu has been a dear friend and a national stalwart in the field of cardiology and echocardiography, and he has been there as a panelist with us today. And I'm sure he will bring a lot of value additions to today's discussion on heart rate as a target for therapy in patients with heart failure and hypertension. Now, Professor Grassi, I don't think needs an introduction. In fact, whenever you talk of hypertension as a subject, it goes synonymous with Dr. Grassi's massive mammoth work in this contest in the entire world. He is the expert reviewer of the 2018 ESC/ESH guideline document on hypertension and the president of Italian Society of Hypertension 2019 till date. He is a vice chairman and then the chairman of the working group of hypertension and the heart of the ESC, as we all know that. Treasurer and then secretary of Italian Society of Hypertension. He's a member of the task force of ESH, the European Society of Hypertension, and European Society of Cardiology for the 2007 guidelines on hypertension. He is the member of the Scientific Council of the ISH for the periods from 2008 to 2012. He has received several awards. The notable amongst them is the John Foucault Award for lecture for the ESH. He has published more than 600 original papers. In fact, if you Google him, the pages for his CVs are endless. You just keep on scrolling and they never end. That kind of a biodata Dr. Grassi has. He's the executive editor of Journal of Hypertension, co-editor Current Hypertension Reviews, editor in Neuroscience Communications, past section editor of Journal of American Society of Hypertension, and a member of editorial board of major international scientific journals. In 2014, he was included in the top 10 hypertension experts rankings made by the Expertscape ranks world's top scientists. He is one of the most cited researchers, I can tell you, most cited researchers in the field of hypertension in the entire world over the last 10 years. He has received the Tejas Jean Award for the ESH 2017 and the Paul Kerner, which is the most prestigious award of the ISH in 2018. I think whatever words you speak about Dr. Grassi are definitely insufficient. So I welcome you, sir. It is an honor and privilege for all of us, for that you are here with us today to enlighten us about your views on making heart rate as a target for therapy in patients with heart failure and hypertension. With this, sir, let me start the contest for this meeting by a small presentation. Can I share my slides now, Dr. Kamal?
Yes, sir. Please, sir. You can share. Yes, sir.
Yeah.
Okay.
Can you see my slides now? Can you see my slides?
Yes.
Yes, sir. It's coming. Maybe.
Yes. Fine.
You can see, Kamal, the slides?
Yeah, Dr. Ponde, please go ahead.
There. So the missing link of heart failure, the heart rate in. So heart rate is a risk factor, risk marker, or a risk factor. Now this was an issue has been discussed over the last 3 decades. Heart rate and cardiovascular mortality. I'm sorry. Heart rate and cardiovascular mortality has been closely linked. In this study, the elevated heart rate increases the risk of mortality in young French men below the age of 55 years. And that includes coronary heart disease mortality, cardiovascular mortality, and all-cause mortality from a heart rate between 60 to 80, 80 to 100, and more than 100. In another prospective study of around 7,000 men aged 42 to 53 years, elevated resting heart rate increased the risk of sudden death in middle-aged women by almost middle-aged men by almost 4-fold when the heart rate was more than 75 as against when it was less than 60. The popular Framingham study also showed us the coronary events increase with antecedent heart rate. In this study, the sudden death strikingly increased with a heart rate above 80 in men between 35 to 65 years of age. Every 10 beat increase in the resting heart rate was associated with a 20% increase in the risk of cardiac death in Framingham study. The FINRIS study is a very popular study. All of us know that. In this study again, with each quintile increase in the heart rate, both in men and women, there was an increase in CVD mortality. And this proportionate increase in women was higher than that in men. So resting heart rate of more than 90 increases the risk of CVD mortality by 2-fold in men and 3-fold in women. Now, how does elevated heart rate play a role in ischemic heart disease? We know that when the heart rate is elevated, it affects both sides of myocardial oxygen demand. The myocardial oxygen consumption increases, and there is also decreased myocardial perfusion. So patients with a resting heart rate of above 80 are twice likely to develop myocardial ischemia. We are all aware of the famous dise study in acute MI patients. This dise study showed that the in-hospital mortality in MI survivors increases with a heart rate less than 60 to more than 100 by almost 3-fold. That is admission heart rate and in-hospital mortality. And the same study also showed that the admission heart rate is also closely related to 6 months mortality in patients with acute myocardial infarction. The CAS registry, with a very popular registry of 25,000 CAD patients with a humongous 14-year follow-up, had shown us that higher the resting heart rate, the higher the mortality over follow-up. The INVEST study in patients with hypertension and coronary artery disease with almost 3-year follow-up showed that the cutoff of around 80, beyond 80 heart rate, the mortality steeply increases, and the outcome of all-cause death, non-fatal MI, non-fatal stroke keeps on increasing as you get increased resting heart rate. This was another study in patients with stable coronary artery disease, which showed that the major cardiovascular event rate was 12% against 9% for a resting heart rate of above 70 versus less than 70. So what is that which the heart rate does? High heart rate reflects an imbalance between autonomic nervous system, and that is what Dr. Grassi is going to talk to us about: increased sympathetic activity and reduced vagal activity. This reduces diastolic coronary perfusion time, increases heart rate, and that triggers the ischemic events, and also reduces ventricular fibrillation threshold, increasing the risk of sudden cardiac death. Now let us talk about heart failure. What is the importance of elevated heart rate in heart failure? The popular MESA study, multi-ethnic study of atherosclerosis, showed us that every 1 beat per minute increase in the resting heart rate, there is a 4% greater relative risk of incident heart failure in general population. Elevated heart rate causes systemic inflammation and endothelial dysfunction and is significantly associated with cardiovascular death, both in patients with HEP-PEF and HEP-REP. And how does that happen? That increase in the heart rate at mitochondrial level decreases energy expenditure and maintains viability. Reduction of heart rate improves force frequency relationship and positive inotropism in patients with heart failure, and also improves pressure volume relationship in aorta, unloading the ventricle. All this causes improved prognosis in patients with heart failure. So reduction of heart rate helps patients with HFrEF. The meta-regression analysis of beta blocker trials, almost 20,000 patients has shown us. If you have resting heart rate of less than 70, you have reduced annual mortality in patients with HFrEF. Heart rate as an independent risk factor in heart failure patients. We know that heart rate of 58 to 64 is ideal for achieving best prognosis in patients with HFrEF. Elevated heart rate at hospital discharge predicts 1-year mortality in HFrEF patients. So when they are discharged, if you have a heart rate more than 80 versus less than 64, if you have less than 64 to more than 80, there is a 41% increase in annual mortality, increased relative risk of annual mortality by discharge heart rate in patients with HFrEF. SHIFT study showed the same to us. And I'm sure Dr. Grassi is going to enlighten us about the SHIFT study details. So I will leave this to him to tell us about what that study showed and how heart rate can be made as a target for therapy. What is the importance of elevated heart rate in hypertension? Now, it has been proved that directly increased heart rate is directly associated with the risk of development of hypertension, progression of atherosclerosis, and is a potent predictor of cardiovascular mortality and morbidity. And what is the cutoff? Cutoff is between 80 and 85 heart rate. In patients with hypertension, increased risk of cardiovascular diseases is associated with increased resting heart rate, and that further increases cardiovascular mortality. We all are very familiar with Palatini's original study published in Drugs in 2006. He showed in hypertensive men and women both the clinic heart rate. Each quintile increase in the heart rate increases the mortality rate, the relative risk of mortality rate, both in men as well as in women. And he said that the strength of correlation between elevated heart rate and cardiovascular risk is as robust as, or perhaps more robust than any of the traditional risk factors. And yet, the guidelines fail to mention heart rate as a tool in assessing patients' total risk. The scores of assessing cardiovascular risk do not include resting heart rate. In our opinion, he said, practicing physicians should start using the heart rate as one of the indicators of patients' total cardiovascular risk, and the most suitable cutoff point is around 85 beats a minute. Increased heart rate is a long-term predictor of cardiovascular events in patients with hypertension. So if you have a resting heart rate more than 85, there is a 53% difference in the incidence of endpoints as compared to when the heart rate is less than 65. The Great India Blood Pressure Survey, and I want Dr. Grassi's attention to be drawn to this fact, a sad fact in our country, sir, that we have a very humongous burden of young hypertensives in India. The young hypertensive population in young adults equates to 80 million people in my country, which is more than the entire UK population. And this is a young hypertensive population in our country. And sadly to say, only 1/3 of them are optimally controlled. Only 1/3. That's a sad fact, sir. I'm sure, sir, you are aware of this study, which was done as an India heart study. It is the largest epidemiological study in the Asia Pacific with 18,000 patients. Total subjects screened were 23,000. Total enrolled were 18,000, or almost close to 19,000, with 1,200 investigators in 355 cities in India in 15 states. My state, Maharashtra, contributed second highest number of patients to this study, 11% patients. What did this study was all about? This study was the home blood pressure measurement in treatment naive patients who are diagnosed to have suspected or very high probability of hypertension in the clinic. These patients went home with a blood pressure machine given by the company. They took their blood pressure at rest 2 times in a day for 7 consecutive days in a week. 3 readings average for each reading, and they came back with this machine which was blinded to them, blinded to the patient. And what we found was in this study was that we have a humongous burden of mass hypertension. The mass hypertension was more common in males. White coat was more common in women. The white coat was around 13% and mass was around 20%. What was even more striking, just like Finrich study, Indian hypertensive patients had a higher resting heart rate, 80 and above in this study. Also, in our study, evening blood pressure was higher than the morning blood pressure. This was second of its kind study. There was an earlier study also done was prevalence of sympathetic overactivity in hypertensive patient, a pan-India non-interventional cross-section study published in 2014. This study also had shown that in Indian hypertensive patients, the resting heart rates are 10 to 12 beats higher than their Western counterparts. This study showed us that sympathetic overactivity in newly diagnosed hypertensive patients is found in almost 2/3 of hypertensive patients in India. So sympathetic overdrive is a very, very notorious association with Indian hypertensive patients. And Professor Grassi is going to talk to us about making that as a target for therapy. And we should not condemn beta blockers in Indian hypertensive patients because most of the international guidelines take beta blockers as a 3rd or the 4th drug in line for the choice of therapy. Sympathetic activity is associated with insulin resistance, obesity, and coronary events. Sympathetic activity, which is the surrogate of which is increased heart rate, is also associated with incident heart failure and patients with HEPREF as well. This is Ferrari's original paper, which showed us that every 10 beats increase in the resting heart rate is associated with 7% increase in the risk of coronary heart disease, 9% increase in the risk of sudden cardiac death, 18% risk in incident heart failure, and 6% increase in the risk of total strokes. So, what it is? Is it a risk marker or a risk factor? Well, in general population, it can be classified as a risk marker. When that is noticed in general population, will you give drugs? I don't think so. Here, lifestyle modification like regular aerobic exercise which increases vagal tone could be the advice to general population where it probably is a risk marker. Whereas in patients with hypertension, patients with established coronary artery disease, and patients with heart failure with reduced ejection fraction, it indeed is a risk marker. Beta blockers without intrinsic sympathomymetic activity, calcium blockers, and ivabradine could be the avenues for therapy for bringing down heart rate in this group of patients. But beta blockers are the only drug which reduce the sympathetic activity. Neither ivabradine does it, nor calcium blockers does it. And we are here to get enlightened with Dr. Grassi's talk for the next half an hour about making heart rate as a target for therapy in patients with hypertension and heart failure. And this, for the delegates who are joined us, this is a book that we publish, 8 authors in the country, Dr. J.C. Mohan, Dr. Panja, Dr. Satyamurthy, Dr. Agarwal, Dr. Brian Pinto, myself, Dr. Kumar, and Dr. Mahala about heart rate. Is it a missing link? It has wonderful chapters on heart rate as a risk factor or a risk marker, heart rate in heart failure, heart rate in CAD, heart rate in acute MI, heart rate in HEPF, and heart rate in metabolic syndrome and obesity. It is worth going through a book. And now I hand over my session to Dr. Grassi with one last slide, which says that life starts and ends with a heartbeat. So heart rate is important. And let us hear the world authority, Dr. Grassi, for his talk on making heart rate as a target for therapy. Dr. Grassi, the stage is yours, sir. Thank you very much.
Thank you very much, Dr. Ponde, for the very nice presentation that I think will well combine with mine. I will try to share with you my presentation. I hope that you will see.
Yes, sir. I see your slide.
Okay. Thank you again for the invitation to this web meeting. After the talk of Dr. Ponde, I think that my presentation will be for sure much more easy. And what I will do is to try to connect the heart rate evidence with the sympathetic nervous system, trying to explain you and reinforce the concept made by Dr. Ponde. This slide refers to what we know about autonomic control of the cardiovascular system. You can see here in this picture the central nervous system, which regulate basically three major targets: the kidney with blood volume control, in the middle of the vasomotor tone, and on the right, heart rate, cardiac output, and in general, myocardial structure. This slide is important. I will have no time later to speak about the connection between central nervous system and kidney, but I remind you that renal denervation, which is a procedure that has been performed with some successes, some unsuccess in resistant hypertension, and in part also in patients with atrial fibrillation, is regulated by this close link between sympathetic activation and kidney function. Well, the sympathetic nervous system overactivity has been shown to be associated to be present in a number of diseases: hypertension, acute stroke, coronary artery disease, heart failure, cardiac arrhythmias, I mentioned before nephropathy, but also close link with metabolic disease. First of all, obesity, but also metabolic syndrome. Regarding the connection between heart rate and hypertension, this is a very old slide taken from the Framingham Heart study. Many of you know very well. And you see here what happens during different age at people with have we have in the initial age an increase in heart rate. This is the red line. Well, these people will have more chance to develop during the year hypertension. Therefore, a suggestion that tachycardia at rest may become a marker of future development of hypertension. And as has been already mentioned, the paper by Professor Julius in Tecumseh area, these are the data looking at the association between a group of hypertensive patients in orange. They called this hypertensive hyperkinetics because they had increase in heart rate, increase in cardiac output, increase in systolic blood pressure, and they have also increased in plasma norepinephrine. And as you know, plasma norepinephrine is a marker, biochemical marker of sympathetic activity. Therefore, finding that these hyperkinetic patients have increased plasma norepinephrine is a strong suggestion for increase in these people of the sympathetic nervous system. And this has important therapeutic consequence, because I think that the group of hypertensive patients, young hypertensive patients with hyperkinetic circulation, elevated heart rate, are strong target for the use of beta-blocking agents. Well, we know that the sympathetic activation is common in hypertension. You can see here some evidence about this. There is a strong, I will show you some data, strong evidence that even in the borderline phase of hypertension, there is an increase in sympathetic activity. This has been shown also more marked in mild, moderate, severe. Independently of the age of the patients, can be seen in young, elderly patients, in pregnancy-induced hypertension, has been already mentioned before, and I will show you some data in wide-coat hypertension and masked hypertension. In obstructive sleep apnea, this is another important target of the therapeutic intervention, relationship with the 24-hour blood pressure patterns, and the close relationship, and we show you later, with development of end organ damage and metabolic alterations. Well, I mentioned that the sympathetic activation is detectable in the early phase of the hypertensive disease. Well, these are data from our group measuring sympathetic activity via sympathetic nerve traffic recording in the peroneal nerve. This is the only method that we can have, is a research approach for directly measuring sympathetic burst in humans. And you can see here, we evaluated 3 groups of patients, patients with so-called optimal blood pressure, therefore less than 120/80 millimeters of mercury, normal blood pressure, and high normal blood pressure. High normal blood pressure means already blood pressure values less than 140/90 millimeters of mercury, but greater than 130/85 millimeters of mercury. Therefore, the last part of the so-called normal blood pressure values. And you can see here in red quite clearly that sympathetic nerve traffic measured by this technique is markedly elevated as compared to the other 2 groups. These are all studies that we did in age-matched patients because, as you know, physiologically, if you assess sympathetic activity in young and elderly patients, you can see that elderly patients are characterized by a sympathetic activation, independently on blood pressure levels. Well, there is also evidence, this again our own data, that if you assess sympathetic activity in normotensive patients in green, mild hypertensive yellow, and severe hypertensive patients in orange, you can see a progressive increase in the last part of this slide in mass sympathetic nerve activity. And together with another approach, these are data taken from Australia, Professor Eisler, who developed an interesting method for assessing sympathetic activity. Is a biochemical technique which allow, a difference from plasma norepinephrine values, to directly quantify the amount of sympathetic activity directly spill over from sympathetic nerves. And the main results are illustrated in this slide. You can see that 2 organs particularly are characterized by sympathetic activation. heart and the kidney. And going straight on this on my talk, there is evidence that in some forms of hypertension, particularly white coat hypertensive and masked hypertensives, therefore people which have white coat hypertensive elevated office blood pressure but normal 24-hour, or on the opposite, masked hypertension, normal 24-hour but elevated office blood pressure, are all characterized by sympathetic overactivity. The message is that independently on how to measure your blood pressure values, if you find an elevation in blood pressure, this is closely associated with adrenergic activation. And before has been mentioned the issue of the 24-hour blood pressure values. So we know that during 24-hour blood pressure values, particularly at night, there is the decrease in blood pressure and the peak status. Well, there are some group of patients which are non-dippers in this slide in pink. And you can see here that also in these patients, there is a marked sympathetic activation. More marked is the so-called reverse dipping hypertensive. Therefore, people who have not a blood pressure reduction during night, but paradoxically an increase in blood pressure, while these patients have marked sympathetic activation, and this may explain why these patients may be at risk of cardiac arrhythmias, particularly during the nighttime period. The sympathetic activation appears to be specific for essential hypertension. This is again the slide from our group, looking at three groups of patients: in green, normotensive; in yellow, essential hypertensive; and in orange, in this case, patients with secondary hypertension. And on the right, you can see that sympathetic nerve traffic is increased only in patients with essential hypertension and not in secondary hypertensive patients. Therefore, meaning that the sympathetic activation is something specific for the essential hypertensive state. I mentioned before resistant hypertension. Therefore, people who have elevated blood pressure despite the use of 3 or more antihypertensive drugs. And it has been thought that these patients are characterized by a very marked activation of the sympathetic nervous system. And this explains why in the early phase, about 10 years ago, it has been attempted to cure these patients with the renal denervation procedure, which lower sympathetic activity. Well, in this slide, you can see at the top picture two representation of sympathetic nerve activity, and in orange, people with resistant hypertension, which have a very, very marked sympathetic overdrive. And this has been also confirmed by the norepinephrine spillover technique. These are data specifically for the renal norepinephrine spillover, therefore looking at the sympathetic nervous system in the kidney. And you can see here, an interesting finding, the elevation in norepinephrine spillover in essential hypertensive patients, but a greater increase in resistant hypertensive patients. And this, I think, is clear-cut evidence of the close relationship between sympathetic nervous system, kidney, and the heart. I mentioned before heart rate, and Dr. Ponde has clearly shown the importance of heart rate as risk factors. Well, I will show you only a few slides. This slide is taken from an old paper showing that if you measure heart rate in different patients with different blood pressure levels, you will see that progressive increase in systolic particularly, but also diastolic blood pressure is linked to an increase in resting heart rate values. And there is a nice relationship between the heart rate values at Holter monitoring and the progression of coronary atherosclerosis. This meaning that heart rate elevation is working not only deteriorating oxygen or myocardial work and increasing oxygen demand, but also for favoring atherosclerosis in the coronary vessels. And Professor Benetton says this slide has been already shown, looking at the relationship between morbidity, mortality for cardiovascular disease and heart rate, showed very clearly that if you have an increase in heart rate, you have a lower probability of survival. And this is true, particularly for male, but also for female individuals. And one of the reasons is that people with elevated heart rate, both men and women, but particularly men, have an increase in sudden cardiac death. Therefore, meaning that heart rate should be in some way a target of the therapeutic intervention. I mentioned that we have in hypertension increase in sympathetic activity, increase in heart rate, but still now we have no clear picture of the mechanism producing sympathetic activation. The majority of studies performed indicate that hypertensive patients have alteration in baroreflex control of heart rate and sympathetic activity, and this explains why in these patients heart rate is elevated and sympathetic activity is elevated. But there are also other mechanisms, particularly the renin-angiotensin system activation. Angiotensin is a substance which increases sympathetic activity, and the same is true for insulin. And this is the link for what I mentioned before between metabolic alteration and sensitivity and produce endothelial dysfunction, favor vascular hypertrophy, cardiac hypertrophy, but also may produce a number of other cardiac factors, tachycardia, coronary vasoconstriction, decrease in oxygen myocardial reserve, and as I mentioned before, pro-arrhythmogenic effects and renal vasoconstriction. And in the story of hypertensive disease, which is briefly depicted in this slide, you can see that sympathetic activation is something which occurs, as I mentioned before, very early, favor the development and progression of the disease, and in a minute I will show you, favor also the occurrence of end organ damage and complicated hypertensive state. I mentioned the relationship between sympathetic activation and end organ damage. I think this is an example of what happens. You know very well that left ventricular diastolic dysfunction is something which is quite common, unfortunately, in hypertensive patients, particularly untreated hypertensive patients, and may favor the development of congestive heart failure. While if you assess sympathetic activity in this group of patients, which is shown here in orange, you will see that there is a profound sympathetic overdrive, greater than the one seen in hypertensive patients without left ventricular dysfunction. Therefore, meaning that the progression of the hypertensive state is closely linked to the progression of the sympathetic activation. I mentioned before, and I am going now to touch the second part of my talk related to heart failure state. This is a scheme, very common, looking at the close relationship between untreated hypertension and development of left ventricular hypertrophy, diastolic dysfunction, as I mentioned, and therefore development of congestive heart failure. And in congestive heart failure, there is quite clear evidence that the new so-called neurohumoral activation, which include stimulation of the sympathetic nervous system, renal angiotensin system, endothelin, and so on, cause the progression of the heart failure state. And this is something which is important because also in heart failure, sympathetic activation should become a clear-cut target of therapeutic approach. Well, the humoral activation you can see here in this slide involves a number of mechanisms. New natriuretic peptide, I mentioned before, renal angiotensin system, aldosterone, activation of vasopressin, and obviously activation of the sympathetic nervous system. And the evidence comes from, again, the study from Australian investigators looking at regional sympathetic activation by the norepinephrine spillover approach that I mentioned before. And again, similarly to hypertensive state, two organs are characterized by marked sympathetic activation in heart failure, the cardiac and the renal districts. And this obviously have an important implication for treatment because cardiac activations means the suggestion for the use of beta blockers. Renal activation means the suggestion for the use of ACE inhibitors and in general drugs which counteract the renal angiotensin system activation, such as, for example, angiotensin II receptor blockers. The evidence, clear-cut evidence of marked sympathetic activation comes from this slide. On the left, you can see neurograms for sympathetic activity in normal subjects, and on the right, in patients with congestive heart failure. And there is no question that the number of sympathetic bursts are much higher in this group of patients than in normal subjects. And the sympathetic activation, the box on the top, is progressive again. Is a clear-cut finding in mild congestive heart failure, is more pronounced in severe congestive heart failure, and is associated with a progressive increase in resting heart rate. There is an inverse relationship in heart failure patients between sympathetic activity and baroreflex sensitivity, and the message is that, again, probably the sympathetic activation comes from the inability of the arterial baroreceptors to control sympathetic activation, like, of course, in normal subjects, and is independent on the ischemic or idiopathic nature of the disease. You can find sympathetic overactivity both in patients with ischemic congestive heart failure or in idiopathic dilated congestive heart failure. Patients, again, stressing the importance of sympathetic overdrive in this group. We did recently a meta-analysis of all studies performed by measuring sympathetic activity by microneurography in congestive heart failure. You can find here the results. I think that, again, in more than 1,000 congestive heart failure patients, clear-cut evidence of very marked activation of the sympathetic nervous system. Why is so important sympathetic activation in congestive heart failure? Well, because, as you can see at the top on the left, there is a close association between the severity of the sympathetic activation and prognosis. If you have patients with very marked sympathetic activity, in this case, plasma norepinephrine in orange, the probability of survival is much lower than in other group of patients with lower level of plasma norepinephrine. Therefore, meaning that sympathetic activation is an independent marker of patient's prognosis. This is particularly true for congestive heart failure, but I would like to draw your attention that the same has been found in post-acute stroke phases and in renal failure. We have no evidence of link between sympathetic activation and prognosis in hypertension, but I think that we have evidence that in hypertension, if you have an increase in heart rate, as Dr. Ponde has shown you, you have a lower probability of survival. Recently, as you know very well, there was a change in the definition of heart failure with preserved mid-range and reduced states with different level of ejection fraction. And there are changes about the hemodynamic profile of these patients, but there is something common, which is the neurohumoral activation, independently on the preserved or not preserved ejection fraction. And this is shown in this slide with evidence that particularly if you have a very marked reduction in ejection fraction in orange, you have a very marked sympathetic activation. But the sympathetic activation is also present to a lesser degree in hypertensive patients, in congestive heart failure patients with preserved or mildly reduced ejection fraction. Taken together, therefore, I will now touch the last part of my talk, the idea that counteracting the sympathetic activation is something important for the patient's survival and prognosis. In general, the ideal cardiovascular agents should be a drug which have good hemodynamic effects, efficacy in a broad range of patients, good tolerability profile, and this will allow to enhance patients' compliance, but also symptom-modulatory and cardioprotective properties for the reason that I showed you. And regarding hypertension, as been already mentioned, we have, according to guidelines, 5 classes of antihypertensive agents. This is a slide taken from the European Society of Hypertension, European Society of Cardiology guidelines. And as you know, a difference from American guidelines, European guidelines still mention the capability to use different class of antihypertensive drugs, and all these drugs, ACE inhibitors, angiotensin II receptor blockers, beta blockers, calcium channel blockers, and diuretics, are on the same level of importance. The difference is made by the type of the patients we have. In other words, if you have a patient with elevated heart rate as marker of greater sympathetic activation, the suggestion from guidelines is to use beta blocking agents because these are effective in reducing heart rate values. And this is the possible mechanism of the favorable effects of beta blocking agents and in general of antihypertensive drugs which may cause symptom inhibition because they allow to reduce heart rate and therefore allow to decrease myocardial oxygen demand, reduce blood pressure variability. I had no time, but spontaneous oscillation in blood pressure during day and night are associated with oscillations, concomitant oscillation in sympathetic activity, decrease in insulin resistance, improvement in trough to peak ratio, which is a marker of the efficacy throughout the 24-hour period of antihypertensive agents, and in general, organ protection and possibly organ damage regression. You can see here from this slide the different class of drugs which we have in current clinical practice for treating essential hypertension. Central sympatholytics, which are now much less used, diuretic, calcium channel blockers, beta blockers, ACE inhibitors, and angiotensin II receptor blockers. And the evidence is that central sympatholytic and beta blocker agents are effective all across all measurements of sympathetic overactivity. But there is a big difference, as I mentioned before. Central sympatholytic agents such as clonidine or monoxidine are less used in hypertension for the well-known side effects. And therefore, I think that from these slides make the difference clear that beta-blocking agents are the preferred drugs to be used when you need to reduce blood pressure in essential hypertension, but also to cause sympatho inhibition. This slide is again shown before, but the importance is related to the fact that if you combine in your patients, hypertensive patients, blood pressure control and control of heart rate, you will have a lower rate of cardiovascular events and therefore an increased probability of survival of the patients. And this is another message which is quite important in clinical practice. Finally, a few words about a specific drug, metoprolol, which is a drug of beta blockers class. You can see here the use in one important study performed years ago, the MAFI study, in which in hypertensive patients it has been shown that the drug is capable to protect to a greater extent the hypertensive patients in comparison with the classic thiazide diuretic, which, for example, is a drug recommended by American guidelines. You can see here that if you use metoprolol, the capability of survival is much greater than diuretic treatment because the drug is capable to reduce total mortality and sudden cardiovascular death. The drug is used in hypertension as an effective drug capable to lower 24-hour blood pressure levels, both systolic and diastolic blood pressure, therefore an ability to cover the 24-hour, particularly for the extended release formulation of the drug. And you can see here that in heart failure, for example, there are a number of beta-blocking agents, but you can see on this part of the slide that metoprolol, together with other two beta-blocking agents, are those capable to achieve better control of heart rate. And metoprolol is effective in reducing sympathetic activity. These are original recording of sympathetic nerve traffic in hypertensive patients before and after prolonged administration of metoprolol with a reduction in the sympathetic burst. And at variance from other beta-blocking agents, the drug appears to be neutral for glucose metabolism. This is another feature of the drug because, for example, if you use atenolol or propanolol, one of the first beta-blocking agents in your patients, there is a good chance that these patients may develop throughout the years a alteration in glucose homeostasis and therefore the so-called diabetogenic effects of some beta-blocking agents. Well, there is evidence that this is not the case for metoprolol, which is also capable to have efficacy on regression of organ damage. These are data taken from ultrasound examination of carotid intima thickness in comparison with placebo treatment. And in pink, you can see the reduction after 1 and 3 years of treatment for the use of these beta-blocking agents. Treatment of heart failure, even preserved or reduce ejection fraction, are based on, as you know very well, on a number of agents: ACE inhibitors, angiotensin II receptor blockers, anti-aldosterone agents. Beta-blocking agents have a fundamental position in this regard, with the possibility of new drugs, such as, for example, sacubitril in combination with an angiotensin II receptor blockers. Well, coming back again in heart failure with beta-blocking agents, clear-cut evidence that you can reduce throughout beta-blocking agents all-cause mortality, particularly in the patients which have a greater impairment in the ventricular ejection fraction. And I think that this slide is one of the most important of my talk. This is 3 major clinical trials in which they provided evidence that metoprolol, together with other 2 beta-blocking agents, are the only beta-blocking agents which has been shown to reduce cardiovascular mortality in severe and moderate heart failure patients. Therefore, meaning that the documentation of the cardioprotective effects of metoprolol is clearly seen in these patients. Metoprolol is something more than, for example, carvedilol, because restores upregulating cardiac beta-1 receptor density. And this is something, again, very well connected with sympathetic overdrive. And these are the data from the trial that I mentioned before, the MERIT heart failure trial. Evidence of 34% of reduction in all-cause mortality in patients treated for the long follow-up time of this clinical trial. Therefore, again, stressing the importance of beta-blocking treatment. Together with the ability, this is a sub-study of MERIT trial, looking at the possibility that metoprolol may also help to modulate the left ventricular remodeling in heart failure patients, and the evidence that in high-risk patients, therefore patients with heart failure and diabetes mellitus, the ability of the drug to lower cardiovascular morbidity and therefore to produce cardiovascular protection is again very well documented. Finally, sudden death, which is unfortunately a major problem in the treatment of heart failure patients, is well controlled by metoprolol treatment with a reduction in the MERIT study of about 40%. And finally, the possibility that particularly in patients who combine hypertension and heart failure, the cardiac death reduction is about half in patients treated with hypertension. This will be my last slide, mentioning that I think that I tried to provide you evidence that in hypertension and in heart failure, an important target of treatment should be elevated heart rate for a number of reasons, but basically for the fact that having elevated heart rate is something wrong for the patients and should be correctly treated with the use of beta-blocking agents. And as I shown you, metoprolol is one of the drugs which have provided the best evidence about the cardioprotective effects. Thank you very much for your attention.
Thank you, sir. Thank you, Dr. Grassi. It was. Can you hear us? Hello?
Yes, sir, you are audible, sir.
Yeah. Thank you, Dr. Grassi. That was right from the fundamentals of sympathetic activity to the use of heart rate as a therapeutic target in patients with hypertension and heart failure. You have made it extremely clear and starting from the elevated sympathetic activity in patients with hypertension and heart failure, both mid-range and low ejection fraction. And you have elucidated the data on how beta blockers are going to help this group of patients. Let me kickstart this discussion with one important thing that we have seen, sir. As I told you, in Indian hypertensive patients, we see that most of them are the younger patients between 30 years old to 55 years old, the major burden of heart hypertension in my country, and majority, almost 2/3 of them, have a resting heart rate above 85. So don't you think beta blocker could be used as a first line drug in a single pill combination with angiotensin receptor blocker or ACE inhibitor with a beta blocker combination? What is your take on this, sir?
Well, as you mentioned in your presentation and as I did in mine, I think that the principal target of beta blocking drugs is the hypertensive patients, even in young age, with which combine elevation in heart rate with high blood pressure levels. This is the target, and I think important to use, for example, as you mentioned, the combination between beta blocking agents and a drug acting on the renin-angiotensin system. Why this? Because this allows to use low dosage of the single compound, and this is something useful for reducing the potential side effects of each single drug. And the second one is that combination treatment is recommended by new European guidelines as the starting treatment. Therefore, if we have a patient with elevated blood pressure, the suggestion by guidelines is to use a combination drug treatment for the reason that I mentioned, that the drug may counterbalance these potential adverse effects, but also they favor a greater hypotensive effects and greater, for sure, cardiovascular protection.
Thank you, sir. Dr. Raghu, what is your take on this combination of metoprolol sustained release with an angiotensin receptor blocker combination, sir, for a young hypertensive patient in India?
Yeah, first let me thank both Dr. Grassi and Dr. Ponde yourself for an absolutely excellent presentation highlighting the effects of heart rate both on the morbidity and mortality in hypertensives and in heart failure. The effect of beta blockers on heart failure has been established much longer than the effect of beta blockers on the heart rate in hypertension. You brought out all those points, Dr. Ponde, very beautifully, very emphatically. Now, in my own experience, when I deal with young hypertensive, I've also noted that these people have a much higher heart rate. The only problem I see to the use of beta blockers immediately is that first, when we start using an ARB or an ACE inhibitor, the initial control of hypertension, I often notice that the heart rate also comes down to some extent. The ones who still persistently have a higher heart rate despite an adequate control of heart rate, blood pressure are the ones where I feel that I must institute a beta blocker. The reason why I don't rush in with a beta blocker is because quite a few of the youngsters are unhappy because of its effect on their sexual potency and other things. So barring this, I have no hesitation to state that in a good majority of my patients who are young, who are in the range of 30 to 45, I very readily start a beta blocker along with an ARB or even a calcium channel blocker if there is a contraindication for an ARB.
Thank you, sir. Thank you very much for that very knowledgeable insight he has given, that once you take the blood pressure under control with ARB or ACE inhibitor and still the heart rate is persistently high, then you can add a beta blocker at a later stage rather than going upfront. And this is to avoid younger people getting side effect of erectile dysfunction and things like that. Quite well taken that Dr. Raghu. Dr. Grassi, we have another question in the chat box which says that for patients with obstructive sleep apnea and those which are reverse dippers, these are typically patients with CKD. CKD patients have a very large proportion of reverse dippers. In them, what could be the drug of choice to treat this peculiar group of patients?
Okay, this is not an easy question to be answered. Anyway, patients, as you know, with sleep apnea, severe sleep apnea, but also moderate sleep apnea, there is a scale, well-known scale of severity of the disease, are characterized frequently by the fact that during night their blood pressure does not go down, but even may increase during sleep. And this, combined with the hypoxia, may trigger cardiac arrhythmias, even sudden death. The suggestion in these patients, however, is obviously beta blocking agents may be good for reducing sympathetic activity, but the major problem in these patients is to solve the problem of obstructive sleep apnea throughout a number of approaches, which may be more or less CPAP, for example, or other intervention, which may in part trigger a reduction in the severity of the sleep apnea. But in general, in these patients, the use of beta blocking agents may be useful to try to reduce on the heart the adverse effects of the sympathetic overactivity. In other words, to protect against sudden death. But I have to emphasize that the major problem is in these patients, and the major target of treatment is to solve the problem of obstructive sleep apnea.
Thank you, sir.
Ponde, can I ask a question at this stage?
Yes, sir. Yes, sir. Please, sir.
It's addressed to both of you. Now, in the beginning of this millennium, at the start of this first decade, there was a lot of interest on heart rate variability as apart from the heart rate, absolute heart rate itself. Lately, I don't find much in the literature on the heart rate variability, though at the start of the decade, there was a lot of articles which took pains to show that heart rate variability, or the lack of it, was more responsible for mortality and morbidity in patients with both heart failure and hypertension. What is your take on it in the current state of knowledge?
Dr. Grassi, can you take that question about heart rate variability? Because I think you had one slide where you said this will not be the topic. I mean, this will not be fitting in today's presentation, but you can talk about it, sir, now.
Well, I think that I had no time, obviously, to approach the issue of heart rate variability. In general, I would like to make a distinction between clinical practice and research goal. In terms of research goal, heart rate variability is a way to assess sympathetic activity with less sensitivity than, for example, assessing sympathetic activity via microneurography. And the reason is quite simple. Heart rate variability is the results of not only sympathetic activation, but also vagal withdrawal. Therefore, you are measuring heart rate variability as a product of two effects. Instead, on the opposite, in clinical practice, I think that we have two ways to assess sympathetic activity. One, to measure heart rate, and this is important. Simply measuring heart rate in the lying patients, you can have information about sympathetic activity. And the other one, the power spectrum of heart rate variability, as Professor Raghu mentioned before, I think is something that can be used particularly in two conditions: in heart failure patients and in the post-MI acute phase. Heart variability in these two conditions may provide the symptovagal imbalance in these patients, which an easy way to assess adrenergic drive in these two diseases. It's a little bit more difficult in hypertension, but anyway, measuring heart rate and heart rate variability in general, I think, is something that clinicians should do for having information about heart rate and in general sympathetic activity.
Thank you, sir. Thank you very much. Dr. Raghu, my take on this would be that if you are treating a patient with heart failure, right? Heart failure with reduced ejection fraction, and you do their 24-hour ambulatory, 24-hour Holter, and if you don't see much of heart rate variability, then these are the patients who have adverse prognosis, very adverse prognosis.
Sure.
That is not so true. That is not so true, I reiterate, in patients with essential hypertension. So heart rate variability is a prognostic marker more in HEP-REF as compared to hypertension. That will be my take on this.
Sure.
Unfortunately, other than controlling the resting heart rate and other than engaging them in a trained, monitored, supervised aerobic exercise program, there is very little we can do to reduce the heart rate variability. As Dr. Grassi said very correctly, we need to reduce sympathetic activity and we need to increase the vagal tone. The vagal tone can go up only by a graded exercise program, cardiac rehab. Unfortunately, in our country, the cardiac rehab has taken such a sad backseat, I cannot tell you. In a city of Mumbai, there are only 2 cardiac rehab centers. Can you believe it? Only 2 accredited cardiac rehab centers, which we need probably 30 or 40. So I think that is where we stand today. Now
May I add something which is not directly related to the issue of congestive heart failure of hypertension. Before starting this web seminar, together with all of you, we mentioned the situation of the COVID in different countries. Well, there is evidence that COVID disease may affect in general the cardiovascular system, probably also throughout an alteration in autonomic cardiovascular control. This is something relatively new, which link is a new field, the alteration in infection disease together with autonomic nervous system.
Thank you, sir. Thank you. That was a great value addition, and I think something which we never knew until now. Sir, one more question from the audience is that how do we compare different beta blockers in treating patients with HEP-REF, and why metoprolol is a drug which we should bank upon, why metoprolol is better than other beta blockers in treatment of HEP-REF?
You are talking about hypertension or heart failure or both?
Heart failure with reduced ejection fraction, HEP-REF.
Okay. I will leave to you the first, and then I will say something more.
Yes, sir. So how metoprolol in HEP-REF how it compares with other beta blockers?
Well, I think that a comparison should be done with the effects on survival rate, on the cardiovascular hemodynamic change in cardiovascular profile, and the antiarrhythmic properties is something also important. Therefore, I think that we have, in my opinion, a different possibility to have a comparison with different beta blockers on the effects on heart failure.
Yes, sir.
And I think that the most important one will be survival, obviously, hemodynamic profile, and antiarrhythmogenic effect.
Thank you, sir. So I think it is very clear that for the reduction of sudden cardiac death in heart failure with reduced ejection fraction, definitely drugs like metoprolol have done better than that with carvedilol. Overall cardiac death and survival is almost comparable with all beta blockers, but sudden cardiac death definitely better with a metoprolol as a molecule. Dr. Raghu, there is another question here in the chat box. Can you take it? That they have said that with relationship to enhanced heart rate fairly clear, addressing sympathetic activity is so crucial in clinical hypertension. So why are we not using beta blockers as frequently as we should be using? Dr. Raghu?
Hello.
Yes, sir. Yes, sir.
Are you addressing the question to me?
Yes, sir. Yes, sir. The question is, with a link in sympathetic activity and mortality so clear in hypertension, why are we not using beta blockers as much as we should?
Let me point out that in the 80s and 90s, beta blocker was one of the mainstay and in fact often instituted as the first drug of choice. Now, while we do talk about heart rate and its effect on mortality, as you pointed out, Dr. Ponde, the heart rate itself, the excess heart rate, the excess sympathetic nervous system is present in about 30 to 40% of the hypertension, not in the majority of the hypertensives.
Absolutely.
And head-to-head, what has been shown is that the control of blood pressure is far superior with the ACE and the ARBs, especially in terms of diastolic blood pressure reduction in hypertension as compared to the use of beta blocker. And that's why the caveat in all the hypertensive guidelines is beta blockers to be instituted as a first line in patients who have both ischemic heart disease and hypertension. Whereas in hypertension per se, the first line of drug choice in both the European guidelines and the American guidelines have been the ARB, ACE inhibitor, or the calcium channel blockers.
Yes, thank you very much, sir.
One comment, very, very short, one comment. I think that we need to make clear that not all the beta blocking agents are equal.
Absolutely.
There are differences between different beta blockers. Therefore, sometimes we think that the beta blocking agent class is made by different drugs with similar properties. This is not true. There are, as I tried to mention you, there are a big difference, particularly regarding the metabolic effects, the compliance and tolerability profile, and obviously in hypertension, the 24-hour blood pressure control.
Absolutely, you said it, sir. So I think we need to choose, when we need to choose a beta blocker in the treatment of hypertension, we need to be very careful. Drugs like metoprolol have better tolerability, very, very safe metabolic profile. They don't alter, metoprolol does not alter lipid profile adversely, and up to a dose of around 50 milligrams a day, even the dose, the side effect of erectile dysfunction is not at all very prominent. When you cross the dose of 50 milligrams per day, probably ED comes into picture in young people. The other important thing which we have to remember is that probably after the death of atenolol as a primary drug in patients with uncomplicated hypertension, I personally feel we have thrown the baby out of bathtub little too early and started condemning beta blockers left, right, and center, which should not happen. In those patients that Dr. Raghu said, after treatment of ACE and ARB, if the heart rate remains higher than 80-85 per minute at rest, and that remains a target of therapy even in patients with uncomplicated hypertension. There is no question at all when patients with hypertension have coronary artery disease or patients with hypertension have mild to moderate left ventricular systolic dysfunction, beta blocker should come as class 1 drug to be included with other drugs in treatment of hypertension along with ACE or ARB. And yes, please. Yes, please.
Sorry, Dr. Ponde. Just to emphasize what you said, I noticed that many times patients are treated with ARB and or ACE inhibitor, and the doctor is satisfied that the blood pressure is under control. But he often in such situations fails to notice that the heart rate is still rather high, as you mentioned. So it is in these patients that complementing the treatment with a beta blocker, especially metoprolol, is very useful, because the additive drop in blood pressure by adding a beta blocker, I have noticed, is not much. Yes. But the control of heart rate gives the patient a much better feeling and a much better control of the future events.
Absolutely. Absolutely. You said it, sir. You said it. Yeah. There are any other questions, Dr. Kamal Kumar, in the chat box, but some of them are not relevant to today's topic, so I did not take them. Actually.
Sure, sir. So right now we got those much questions only, sir, and yes, sir. So some of the things were revelation for me also. So as you rightly said, usually with cardiovascular comorbidities, the beta blocker no doubt becomes a first choice of drug for hypertension control. But even with the patients who do not have this comorbidity, still if they have heart rate more than 80, actually these beta blockers should be given along with the ARBs, ACE inhibitors, etc. Definitely point well taken, sir.
Yes.
Yes.
I also want to bring out for the audience's notice, and Dr. Grassi also, sir, that in the India ABPM study, ambulatory blood pressure monitoring study of India, which is another very big ABPM study in the Asia Pacific of 18,900 patients of ABPM, we did in almost 23 states in the country. We found that 42% of our patients have abnormal dipping pattern.
Okay.
And out of that, 17% have a reverse dipping. Most of them were women, most of them had OSA, and most of them had CKD, this reverse dipping. That's why I brought this to your notice, that abnormal dipping is a very, very common problem in Indian subcontinent. Very, very common problem. Unfortunately, ambulatory blood pressure monitoring is not very commonly practiced in this country because of the cost, availability, and patient acceptance is another factor. So therefore, we now are probably launching another study in 3 months' time from now about how to treat these patients with abnormal dipping patterns, and we will probably have some good revelations from that in 3 years from now.
Good, very good.
Thank you, sir. Thank you, sir. So, Dr. Kamal Kumar, I think we are now reached the end of the time. I think you can.
Yes,
wind up. Yeah.
Thank you.
Yes, thank you.
Sir, I'm taking this privilege.
Yes, sir.
I'm taking this privilege to give vote of thanks. I think wonderfully presented, Dr. Ponde, and moderating the entire sessions with your beautiful insight about the heart rate as a missing link. No doubt, I think it's a very strong message. All physicians should take this forward in the clinical practice. And we are really in depth, to Dr. Guido Grassi, beautifully present a sympathetic overdrive. I think he has clearly come out with the statement that sympathetic overdrive is the hallmark of all essential hypertension and cardiovascular disease. And it should be the integral part of treatment with the ongoing treatment of hypertension as well as the beta blocker. I think that's a wonderful, discussion we had. And thank you, sir. Dr. Raghu, wonderful with a vast experience in clinical cardiology. This support, and thanks to all our respected audience. Truly, we salute your patience. With this COVID pandemic, you have take out some time and attended this program. So thanks, sir, once again, Dr. Guido Grassi, Dr. Ponde, and Dr. Raghu. Wonderful, sir. Thank you, sir.
And thank you, Kanuji, and thank you, Kamal Kumar ji, that bringing Dr. Raghu here and bringing Dr. Grassi here to be with us was a simple honor and a privilege. I'm so indebted. I'm so thrilled to have this session with them. Dr. Raghu is the president of Indian Academy of Echocardiography this year, and our conference is there coming in coming October. And I'm going to take his suggestions also to formalize the scientific program of this conference. And Dr. Grassi, as I said, is the world authority in hypertension, and to be with him could never have been possible in my lifetime without this pandemic and this virtual platform. So thank you very much indeed.
Thank you. It was a pleasure. It was a pleasure.
Thank you.
My sincere thanks, Dr. Grassi, Dr. Ponde. Ponde is a very good friend of mine, so he tends to flatter me a bit, but his own academic achievements are fantastic. And I also feel quite deeply, and I'm very deeply grateful to Ajanta Pharmaceuticals for bringing me on the same podium with Dr. Ponde and Dr. Grassi. Thank you very much. Good evening, Dr. Grassi. Have a wonderful day, wonderful evening, and also a wonderful weekend.
Thank you.
Thanks again to the entire team, and let me say goodbye here. Hopefully to meet sometime again in the future. Thank you.
Thank you, sir.
Yes, sir. Thanks a lot. Thanks a lot.
Very much, sir. Thank you.
Thank you, sir.
Thank you very much.
Bye-bye.
Bye.
Thank you very much.
Thank you.